Hello, Andrew Colsky with Therapy BTS, Therapy Behind the Scenes. Today, we are going to be talking with Jenna Stone. Jenna is a therapist who works with OCD and eating disorders, and we're going to talk about different types of OCD treatments and how they relate to the work she does. So, Jenna, welcome, and could you introduce yourself to the audience?
Yeah, sure. I'm Jenna, and I'm a therapist in Maryland. And as Andrew said, I treat eating disorders and OCD.
Fantastic, fantastic. So, let's learn a little bit about Jenna first. I know you shared with me that not only do you treat these disorders, but you're someone with lived experience as well. So tell us about, how did you even get interested in the counseling field at all?
Yeah, so when I was younger, I went through treatment for an eating disorder. I've coming up on 10 years of recovery for myself, and I just always wanted to kind of give back to the field that helped me find wellness and sharing some of the insights that I had along the way, kind of maybe some things where we're missing when people go through eating disorder treatment and recovery, and just like really giving more voice to lived experience. And how we really utilize our treatments.
Mhm.
Um, one of the things was just as someone with an eating disorder and OCD, how that wasn't fully addressed in eating disorder recovery all the time, and how like sometimes the eating disorder would get better and the OCD got worse, and then like you would just kind of go back and forth, back and forth. And so really being able to fill this gap in the treatment world is what
Mhm.
got me here.
Great, great. So as a patient, when you first were seeking out treatment for yourself, um, were you able to find effective treatment right away, or did you kind of have to go through a couple different trials before you figured out what was really going on?
So I was in denial about my eating disorder actually. In the beginning, I actually started therapy specifically for OCD. I knew that was a problem. I knew it was a thing, but when it came to my eating disorder, I masked it through sports and things like that. And it we live in a culture that says that I was doing things good. Like I was like, oh, that's great that you run that many miles every day, and my behaviors were praised by society, yet I was killing myself. And I didn't really know until I was medically compromised that I really had an eating disorder. So from the beginning, I did not just seek out eating disorder treatment, and I didn't know anything about it. And I lived in an area where there were pretty much no specialists with that. So that became a huge problem for me because I quickly got into the place where I needed higher level of care.
Right, right.
So
So can you tell us a little bit about, you know, you said, you're treating eating disorder and then that makes the OCD worse and vice versa. So what were some of your early experiences as you were going through treatment? What was going on for you as a patient?
um I think with treatments, I the first thing that came up was, wow, I'm really dying. Like this is going to kill me. That didn't actually register to me how fatal and deadly eating disorders are. I had no idea that what I was doing was a problem. It felt like, I'm just becoming a better runner and things like that. So really learning the medical piece of that, and then doing an eating disorder treatment, our we use enhanced CBT. So I went through that as a patient doing CBT. I also did some DBT, things like that. So really just getting immersed in evidence-based care. Whereas in the outpatient world, I know my first therapist I ever had said that they treated OCD, but it became clear in time that they actually did not. They just advertised as an OCD therapist, and they didn't really have any training in OCD, and that was also a big problem. So that in that way, I was able to kind of like learn about the difference between talk therapy and evidence, what we think is more evidence based things, where we're challenging our thoughts and how that impacts our emotional experience, and really getting in tune with those really uncomfortable somatic sensations, and really starting to find recovery that way.
Right, right. So I'm going to ask you a question I ask pretty much everybody, and I always get the same answer. When you were in school learning to become a therapist, did you get any training at all about OCD?
I did,
You
but
did?
not from my school.
Ah, okay.
I did a lot of intensives on the weekends, things like that. So that's actually where I did my exposure and response prevention training was while I was in graduate school. I got trained in ERP. It was I think like a 4-day intensive or something like that. So I was always going to conferences and doing trainings and things just kind of on my own because that was completely lacking in my MSW program. And I really enjoy learning. So yeah.
Okay. So you did not break the chain here, because the answer I get from everybody is nope, never learned anything about it in school. So you taught yourself through your own, education and conferences, but your school did not provide information.
Yeah, because when you're a student, one of the things that I think people should know about if there's any students watching this is you can get student discounts, which is really great. So one of the things is like Psychotherapy Networker. You can go to that really inexpensively when you're a student. So I was kind of trying to go to all the things that I could while I had that student ID that kind of gave me those discounts because training is kind of expensive.
Yeah, oh yeah, definitely. Um, but I, you, because you had lived experience with this, you knew it was something that needed, special care and treatment. And this is something, just for the audience, I say this a lot and I try to continue to reiterate it. When you are seeking out any sort of health care, whether it be mental health care, whether it's, a medical doctor, whatever it is, ask the questions. How much experience do you have treating this particular thing? What type of training do you have? How many patients have you seen? What are the techniques that you use? Just because someone says they treat something, as you just shared, doesn't necessarily mean that they are qualified to treat that thing. And I run into the same issue as well. So many patients come to me for OCD after saying basically what you said. Well, I went to someone who said they treated OCD and we just kind of talked for about 2 years and nothing happened. And so I figured something wasn't right. And it's a shame because they wasted a lot of time, they wasted a lot of money, and there was no OCD treatment happening. So don't be afraid to ask the questions when you're seeking out mental health care. Okay, now that we're done with that commercial,
Mhm. It's very important though.
it is. It is.
Because and part of my journey was also before I became a therapist, I did a lot of mental health advocacy. So in undergrad, I was part of Active Minds, and then I also got involved with NAMI. So I did like running those support groups and things like that. So really from the peer side. So I did a lot of that. And these are the messages, right, that we told people. Like I would see, just community members, peers, they're like, oh, well, I am in therapy. And I'm like, well, that doesn't sound like you're really getting treatment, though. It sounds like you're just taught. And that's great, right? It's good to be able to have a safe person that you can be vulnerable and have your emotions validated an hour a week or whatever. But there's a whole different, it's a game changer once you're actually participating in our evidence-based treatments and the things that, we always say CBT works and things like that. And it works for a lot of people. It's not always for everybody, right? Everybody's so different. But overall, like I really strongly encourage people to find therapists specialized in particular modalities that are, the research shows that it treats your condition that you're looking to get relief from.
Mhm. Absolutely, absolutely. I agree. So you then, you did this training on your own while you were still a student. You got trained in
I did this space training while I was a student too. So if
Oh,
there's providers out there, everybody knows how difficult it is to get space trained. The very moment it's advertised, it's filled, you try to sign up. But if you're a student, so just wanted to
yeah.
put that out there.
So for the audience, space training, give us the synopsis.
Oh, it's space stands for, it's really cool, right? It's space. It stands for supportive parenting for anxious childhood emotions. And it's a really cool approach because instead of putting a kid in therapy, you can just work with their parents and
Mhm.
teach their parents to not accommodate the anxiety as much. So then the kid is kind of barred from being, like the identified patient in the family and that whole dynamic there that can get really challenging. And I believe the research is showing that it's just as effective as putting your child in a CBT
Mhm.
treatment. So,
Yeah, I think it's, like for me personally, whenever I'm working with a child, I recommend the book to parents to read so they can learn how to, stop accommodating their child and actually making things worse while they think they're making it better. Um,
mhm.
it's very helpful, and I'm all in on all the techniques and everything through the space program. um, so yeah, that is a very important piece, is this accommodation piece, and it can be so counterproductive, but so hard to understand from a parent's perspective. Um, so you started off with training. You had space, you did ERP.
I did
When
comprehensive model for skin picking, trichotillomania, all of the I did all the things. So
Great,
yeah.
great. But at the time you were in school, you did not do I-CBT yet, correct?
I actually started learning I-CBT, which stands for inference-based cognitive behavioral therapy. So when we talk about ERP, we're in the appraisal model. With inference-based, we're talking about the inferences that people make from having like one data point and then like another conclusion or something like this must mean that or things like that. And inference, I was really in graduate school really struggling with my own OCD, and I'm in so many different provider groups, and I met a group of lived experience clinicians with OCD. We were hearing about I-CBT, and we kind of formed our own group, and we were our first client, so we just did it on ourselves. And I was the only one that was still student, but I was very welcomed in this group, sharing all of our insights along the way, having the most nuanced discussions about the way that we as just people, right, experience OCD. It's not just all fear-based. There's also disgust-based OCD.
Mhm.
And how do we even treat that? Because if we've gone through like treatments and we weren't getting better, or we didn't have this like whatever kind of recovery that we're hoping to get, what can we do? Like how like doing it on ourselves, I think, was so helpful in just like being able to apply the modality. And I know ACT does this as well, where they really want, if you're going to be an ACT therapist, you have to do ACT on yourself. So this is kind of how we learned I-CBT together, and we did some consultations and things like that.
Great, great. So I want to talk more about that, but first for the audience, because there are so many acronyms in this field. ACT, acceptance and commitment therapy, I-CBT, inference-based cognitive behavioral therapy, ERP, exposure and response prevention therapy, CBT, cognitive behavioral therapy. So there's a lot of things to know when you start to, delve into OCD and related areas. So tell us then, if a patient comes to you, and let's start off with just OCD, not an eating disorder, just plain old
Sure.
OCD. What type of treatments do you offer to them, and explain to us what is the difference in terms of what they would actually experience when they're working with you?
Yeah, sure. So I first of all, I always, try to figure out what themes are coming up for them, and then figure out is this something that looks similar? So we'll take someone who clearly has more like fear around negligence or something like that, where they're locking the doors or something like that compulsively, and I try to like look at it like you have the why box, and you start to notice like, okay, certain people, like certain themes of OCD pop up for the same kind of people. What I-CBT would say, they have the same kind of fear possible self or vulnerable self theme. They kind of get all bundled in together. So when I see that clinically, I'm like, okay, we should go I-CBT, but I always give them, informed consent. Like we can go through a hierarchy. If this thing is bothering you so much that you keep checking so much you can't even like get through your day, then we can go through a hierarchy and try to get you to a place where you stop doing that. right? So that would be more the exposure model, or we can kind of go upstream and talk about this faulty reasoning process that keeps you trapped, that keeps you stuck, where like, you're being irrational, this doesn't make sense, but you still feel like you need to check.
Mhm.
You're just drawn to it and you don't know why.
Mhm.
And there's so many different ways to go about it, right? Um, and then it really depends on what people are presenting with. And another thing too is if there's that disgust-based OCD around contamination. I use Rich Gallagher's mastery approach for that. He was actually one of the clinicians in my group, and like these are the real discussions we were having, where disgust, that's processed in the insula, not the amygdala, so it's not going to habituate as a fear-based response would. So the idea is that if you're scared to get germs from taking the trash or whatever, let's come up with strategies that allow you to do the thing that you want to master, right? Before, instead of just like going like, I'm not going to take the trash out because there's germs and I could get sick, or I could get other people sick or whatever. We're just going to put gloves on and do it that way. Can you do it? Can you tolerate that? Is that fine? So
Mhm.
in those kind of situations, we use some accommodations. So I try to look at, what is the client, what are their themes, and get more nuance. Is this disgust? Is this fear-based? What's really going on here? And are a lot of the things linked? So they always have a choice.
Mhm.
But I know before we started recording, the way I do ERP is not the Edna FOA style. It's always values based, like kind of what driven by the client's goals, like where is OCD getting in the way, and how are we going to get there? And
Mhm.
that's kind of how we build that hierarchy if we go that route.
Great. So really, it's depending on your particular patient, you're developing a customized treatment plan.
Everything's so customized. Yeah.
Right.
And I will troubleshoot things if I'm like, I don't think this is working. Do you think this is working? How's this working for you? And then I'll like, do you want to switch gears? Do you want to try I-CBT now? Because some people they've only heard of ERP, so they only want to do ERP, and that's fine. We can start with ERP and see where we go.
Mm-hmm. Mm-hmm. So, okay. So now let's make it a little bit more complicated and let's start talking about eating disorders and how that plays in to this whole bigger picture with OCD.
Sure. So when you are working with someone with an eating disorder, obviously we start with assessing kind of where their symptoms are. There's the way I look at eating disorders is it's a mental illness. So it's a cycle. Thinking about OCD, that's all in someone's head, right? And sometimes we see the behaviors and sometimes we don't. They might be doing mental compulsions and things like that. The same thing is going on for people with eating disorders. Sometimes people aren't actually engaging in eating disorder thoughts, but they have the ED mindset constantly. Their thoughts are just consumed with, should I eat this? Should I not eat this? Oh my God, like, what am I going to do? Or if they're just working out, like, how many calories, it's a mental illness. So that's why we treat it. And then we have the behavior. So assessing kind of like the psychological state of the individual, the behaviors that they're using, the frequency of those behaviors, and then the medical piece. That is the huge piece. So when you work with eating disorders, it's not just the therapist and the client. It's a team. We are a team. So that includes a medical doctor. We always have a medical doctor on board, a dietitian. That is crucial. One of the hard things about eating disorders is because of insurance and things like that. People are like, well, I can afford to see you, but I can't get a dietitian. And then that gets tricky because then I'm kind of like, I'm not a dietitian. I don't have any background in medical nutrition therapy, and that's just outside of my scope. And that gets really tricky when there are those barriers. But having a dietitian is critical on the team.
Mm-hmm.
So we have that, and then a psychiatrist if someone needs psychiatric medication. So we work as a team with eating disorders, and as a team, we're assessing, what level of care does the client need to be at this particular time? Can we keep them outpatient? That's always kind of our goal, is to try to keep people outpatient. I feel like we do a lot of good work outpatient, and where people are in their environments and communities and able to kind of keep up with things. So we need to first target the medical piece, and the medical piece is going to be based on specific labs and things like that. A lot of people think that eating disorders, the thinner you are, the sicker you are. And that absolutely is not true. That's incredibly fat phobic. You can have people, for instance, in larger bodies that, people, even their doctor might be telling them, like, hey, you need to lose weight because your health or whatever, your BMI is blah, blah, blah. And then they freak out and they lose all this weight. And then all of their friends are like, oh, you look so great. But what they're doing is so much damage to their body. The research shows that about 95% of people that pursue intentional weight loss will gain that back plus more within 3 years. People just don't keep it off. And the people that do keep it off will tell you that it's all your fault if you gain it. So then there's that piece too. And what we know is that existing in a larger body is less of a medical problem than just going through this weight cycling that happens in eating disorders and disordered eating and just your old-fashioned dieting. So when people are going up and down on the scale, they're doing severe damage to their body. And that's what we want to prevent. We want to prevent people from going up and down and just being able to just be in their body. And unlearn diet culture. That is a huge piece of eating disorder recovery, is to kind of unlearn all of this stuff that keeps us sick.
Right, right.
So with that said, you can't just look at someone and be like, oh, your eating disorder's fine. You can't do that. So we have to really get into what I like to do as a therapist, right? I'm looking psychologically, kind of what is their state? How frequent are they engaging in behaviors? Are they suicidal? That is a huge reason why eating disorders are so deadly, is because of suicidal ideations.
Wow. So can you give us an example of let's create this hypothetical patient who has both an eating disorder and OCD. What might that actually look like in terms of their actions, their thoughts, those types of things?
It depends on where they are in their eating disorder recovery. And I can give you a couple different scenarios here. So one of the things could be someone with OCD could get stuck on a rule or something like that they've kind of made up for themselves, whether it's influence from diet culture or other people, but they get really fixated on, if I go over this, if I go over so many calories a day, I'm going to gain this many pounds or something like that. And that is not just people with OCD too, because what happens in eating disorders, the more malnourished someone becomes, the more obsessive they become. So as they go through refeeding, that obsessive thinking goes away. For people with that actual have OCD in addition to the eating disorder, it gets really severe, where some of it could be just more health focused, where we're told that eat this, not that, or you're going to die if you eat this, or you're going to get sugar diabetes, if whatever it is. People get kind of really scared of eating anything because of the messaging that's out there, and that feels very real to them. So they can take it to the extreme. For instance, one of the things I see with OCD and ED, this mix, is a lot of people with what we call orthorexia. Have you heard of that term before?
I have not. Please educate.
Orthorexia is it's an obsession with healthy eating, that you can imagine that if you're cutting out things, any type of nutrients, core nutrients, because you think that, oh, that's going to cause cancer, or this is not good for me, or whatever, you're going to get someone who's really malnourished. Or it can lead to compulsive exercise. What if I don't, you're going to hear more OCD thinking here. So what if I die? Someone with health anxiety, they might feel that they need to run every day or something like that to keep up their cardiovascular fitness or something like that. And that it has this OCD flavor to it. And most likely those people, I'm finding, and I don't know what the actual research, I don't know if there's been research, but a lot of them do have OCD that end up having this orthorexic presentation of an eating disorder. Now, currently, we diagnose it as OSFED and DSM-5 because there is no diagnostic term, and that might change in the future. But it is kind of this just intense focus on healthy eating that leads to malnutrition and more obsessive thinking. So they can convince themselves that, eating things are going to make them sick, things like that.
So when you're dealing with a client who's got all that going on, what do you find to be the most helpful approach from a therapeutic approach?
So with eating disorders, always starting off with more of the CBT stuff, and then um, you know, one of the things that I here, let me walk you through it this way. So in CBT, right, we have behavioral experiments, we have exposures, we have all these really great tools that we can use to kind of help someone. Someone may struggle with um, if they're feeling like other people are looking at them. For instance, they go to the grocery store and they have an eating disorder. They might start thinking things like, well, what does the cashier think about the foods that I'm purchasing? Do they think that I eat this way, or whatever? That blending, there's that cognitive blending there where people think that certain eating a certain food means you're a certain way, or whatever that is.
Hmm.
And so we can go through like behavioral experiments, do a survey, a poll, like, hey, cashiers, what are you thinking about during your work hours? And then we get the poll results are like, yeah, I'm thinking about my lunch break. I'm thinking about how annoying these customers are. All of these kind of things. They're not thinking about what you're actually purchasing. And the problem is we can go through all these behavioral experiments. They can go out and do their exposures where they're going to the grocery store. They're feeling less anxiety in their body and they're able to kind of navigate it, but they're still getting stuck. The new problem that comes up that I keep seeing, and this is where I go into using some I-CBT actually, is, but I know that they don't care, but I feel like they do.
Hmm.
And that's where we start like breaking down this reasoning process. It's like, well, of course, we live in diet culture, and it's so validating for people where they're like, aha, like no wonder I feel this way, because my whole life I've been raised in this culture that teaches me that you are what you eat. And you have to unlearn that stuff in eating disorder recovery, because it's not true.
Right.
It's not true. And what we know is that the way that we look is just, I think it's like 70% of our genetics really determine our weight and things like that. So a lot of people think that they can fight, just like an OCD, health anxiety. I can fight. I will never get this disease if I just, take all these vitamins. I don't know if you've ever had a client who takes like so many different vitamins to prevent this horrible illness from ever happening. And you're like, actually, that might not be good for your liver. So they have to really reflect on, right, the long-term sustainability of engaging in, is this in alignment with their values? Like, do you want to die? Like, what's going on here, to kind
Yeah.
of get to that point? But that's kind of like where a lot of this is cognitive behavioral, but you can work on the cognitive distortions and validate people at the same time. And that's why I like getting into the thought process.
Hmm.
It's like, well, what keeps you stuck? Why do you keep thinking this? And for some people, fat phobia is real. Like, that is real. We can't CBT someone out of that. We can't be like, oh, well, just change your thoughts. The world is so cruel at the end of the day to fat people.
Hmm. Hmm.
And that's where social change, and that's where I think a lot of us who've gone through eating disorders, we go through recovery. A lot of us are therapists now. A lot of us are advocates. And we see these harmful systems of oppression, and we're trying to fight them. And that's kind of what keeps us, I guess, in recovery, right? Is that we're still trying to kind of change this world, because we see how awful it is toward people in different bodies, and making people feel like they're not good enough or loved or worthy or whatever it is.
Yeah. Yeah.
So
No, it can be very challenging for someone who is kind of caught in a certain thought cycle, and they can pull up their evidence to support what they believe. But um, you know, I'm curious. You talked about I-CBT. We've mentioned it a couple times.
yeah.
Can you give us a deeper understanding from your perspective, like what makes I-CBT different from the other things we've been talking about? How would somebody recognize that they're doing I-CBT?
Well, we would talk about that. We're gonna jump into some I-CBT if that's cool with them, if they want to kind of start exploring like what keeps them stuck into thinking these things. So with an eating disorder, for instance, there's a lot of stuff going on there. Someone might be like, okay, they're at a party and they feel like, if I eat this cake, I'm gonna gain a ton of weight or something like that. Right. And then you have all that checking behavior and stuff that happens. And we know the reality is that your weight, especially if you're in a assigned female at birth who gets, your menstrual cycle or something, that's gonna that's not a good, that's just torture. Weighing yourself is just torture to look at those different shifts in someone's weight on a daily basis, because people get very compulsive about that. And again, it goes hand in hand with malnutrition. So someone who is like thinking that, oh, I can't have this piece of cake because I feel like I'm going to gain blah blah all this weight and then everything's going to be horrible. That's kind of where I find I-CBT really helpful, because it's showing them that clearly they know that's not true. They know that's not true, that they can have the piece of cake, but something's preventing them. And it's fear. It's all this fear. So let's go upstream and figure out why are they reasoning this way? Some of the reasoning does come from our somatic sensations, the way we feel in our bodies. Some people, that we have interoceptive differences. So bloating and things like that can be really tricky for people, where they're like, well, I feel like I just ate that and then I felt bloated. So how do I know that eating it again isn't going to make me feel that way? And being able to, look at what's sustaining that kind of thought process and why it feels real, that they're gonna, and in the end, like, is gaining weight so horrible? No, it's not. But society's going to tell us that it's the worst possible thing you can do.
Right.
So there's a lot there. So with I-CBT, we're looking at, what I really like about I-CBT is it explains OCD in particular, right? It's evidence-based for OCD. It explains OCD in a way that I think makes sense for those of us with lived experience. There's just like, aha, because we've always been told as clinicians that OCD it's intrusive thoughts, like, oh, I have an intrusive thought. It just popped in my head. And those of us who have OCD, sometimes it might feel like that is real, that is a real experience. But overall, this idea of obsessional doubt, where like you're doubting yourself and your senses and what you know to be true, that feels more like that's what's going on. And I think the language of I-CBT really just lands well with people. They're like, this is it. Like, it just makes sense. So we're looking at the obsessional doubt and what things can trigger that doubt. It could be very simple, right? You could just get in your car and then the what if pops up. Well, what if my tires are, what if they're low? And, whatever, you turn on your car and then you check, I don't know, everybody's cars are different, but mine, I can see like how much air is in all the tires and things like that. But I might also have another doubt, like, well, what if that's wrong? Like, what if my car is just not reading it right? I need to go check, things like that. So it's really looking at, why are you getting sucked into this? Why does that keep coming up? And just like with CBT, we have downward arrow. That's one of my favorite things from CBT. And in I-CBT, we're looking at the feared possible self. Like, what's this like core fear kind of thing, or your vulnerable self theme driving this? Like, what is so much in common going on underneath? And in eating disorders, there is a fear. A lot of people just fear being fat, because look at the way that our world treats fat people.
Yeah.
That's real.
Yeah. Yeah. Well, let me define two things there just for the audience. So you talk about downward arrow in CBT, and downward arrow is basically a technique that allows us to kind of get to the root of a thought or something. You kind of keep digging down. Why do you think that? And why do you think that? And why do you think that? Until you get to your root. And the other thing you talked about is the obsessional doubt that people have. And basically, when we talk obsessional doubt, the way that I describe it to my patients is, you have all the facts that are there, but for some reason you still don't believe them. So, I know that I'm, sitting here talking to you on the computer, but then I'd have this doubt, well, am I really? Maybe that's just like something that I'm imagining and it's not actually happening. Or maybe she can't really hear me and she's pretending that she's able to hear me. I can come up with all these, what ifs and possibilities and all this doubt. And that becomes debilitating at times, because you can never, not that you can never, it's hard to get out of that cycle if you're, if you keep getting dragged into it. Yeah, it's a really It's a really interesting field, and I think just the way that you have been able to describe so many of the different things that you deal with is important for someone to go back to the first part of the conversation. We were saying you really need, if you're going to be treating OCD, for example, you need someone who knows and understands how to treat OCD. And you've shared with us so many of the different types of knowledge and things that you have to be able to do that effectively. And it's not something that you get from your traditional graduate program where you learn to become a therapist. So,
And also eating disorders are not even, I don't,
true, true. We don't cover
I
those
know
either.
this is going to sound really negative, but I'm just going to name it for what it is. Probably, and I graduated recently. So the majority of people graduating with their master's degrees in social work or counseling or whatever, they probably still think that OCD is just hand washing and being neat and organized,
Mhm,
and that eating disorders only target thin, white, affluent teenagers.
mhm,
None of that is true.
right,
None of that is true.
right.
And so if you are a generalized practitioner, you need to be assessing, keep an open mind. Like these disorders are really challenging and they can affect anybody. They go under the radar so much for so many people. And I do know, like, I recognize my own privilege in these systems and how I was able to eventually get help and think, like, yes, I got the wrong help at first, but still, like, people looked at me, they're like, oh, it sounds, you might have anorexia. I was like, yeah, maybe I do. And I wasn't sure because, the whole like running thing or whatever, I was like convinced I was just training for a marathon.
Right.
Right? Maybe I was inferentially confused. I don't know. Um, but there's like a really, these disorders are really challenging and disabling for people.
Yeah. Yeah.
And there
No,
is help, right?
it's and this is, we talk about, what we don't cover in school for counseling in master's programs. And it's the same for doctors and psychiatrists. Now, they do get some training, but I've heard so many stories of like psychiatrists, for example, who also believe if you're not washing your hands or doing some physical compulsion, then you don't have OCD.
Yeah,
Um,
and that's actually a huge part of my job is the collaboration piece with other providers who are also and it's not a fault of theirs, it's the system. The
right.
issue is the system. And sometimes I have to make these extra phone calls when I'm working with a client. They already have their general practitioner from childhood or something, or their pediatrician they're still seeing since they were a baby, and I have to make these phone calls and kind of go do the psycho ed piece and like, this is, hey, this is actually what's going on. Or um, you know, your patients, they may not look like they have an eating disorder, but they do, and they're really struggling. And I need you to run these labs. These are the standard labs that we, want to check to make sure that someone's not dying like right now, because these are highly deadly.
Yeah.
And yeah, so a lot of my job is in fact kind of doing that outreach to other providers in a way where, people do want to learn, but then we look at the systems and it's hard to find time, right? It's hard to find time to sit down and like, you might say like, oh, I want to learn this new modality, but I have kids and I have all this other stuff going on, and and there we're just, so busy, and it's hard to kind of get that out there. And I wish med school, graduates, like all these schools would talk about these disorders more and more.
Yeah, and that's one of the big things I've been talking with several folks at the International OCD Foundation about this concept that is there a way that we can get some OCD education as part of the traditional curriculum in, graduate school for therapists even, just because they should at least be able to be trained on how to recognize it and diagnose it. Forget about treating it. Let them refer it out for treatment if they don't want to,
Mhm.
but at least recognize when it's there. And like you say, the training, there's so many additional things that we as therapists need to learn when we get out of school. And then comes the time and all that. And what I found in my personal situation was, I get out of school, I start to do my internship, my residency, all this type of practicum type of stuff.
Mhm.
And what would happen is in the very beginning when I was learning, a client would come in and I'd be like, that's strange, trying to figure out what it was. And then I'd have to go teach myself how to treat that particular disorder. And then, that's how you start to get your education. Like that's why you do a practicum and a residency and all.
Yeah.
So yeah, it comes from being thrown into the fire and you got to figure it out because you're not going to just let your patient flounder. You do your research, you do your work.
Yeah, and you can do the thing where you get to a point where you're like, you know what, I need to refer out, and then of course, oh well, the people that could treat them aren't taking new clients, or they don't take their insurance, or whatever the barrier is, and ethically, what do you do? And it can get really challenging at times. And so I'm always upfront with people when I feel like we have to take like maybe a different route or a different approach or something like that. That I'm learning about this too, and that's what happened with the ICBT community as people were learning. They all just told their clients like, hey, this has been evidence based for 20 years, but we just haven't been doing it in the United States. And so a lot of us are learning it. And if you give your clients informed consent whenever you're learning a new modality, like want to be patient zero kind of thing. And like I said, I was my own patient zero, and I learned so much from that. It was amazing. But letting people know, like, hey, I'm still learning this too. Give them the options. You can try seeing other people, but it looks like people are filled right now, or people aren't taking your insurance, or we have this relationship and blah blah blah, whatever. It can be really hard to do that. So I guess for me personally, I love, like, I'm always, when I'm not working, when I'm not seeing clients or doing my notes or whatever, I'm always like reading. This is just what I do in my free time. um but I know for some people they can't. Like they just need to turn off, and I totally respect that too.
Yeah.
So
Yeah. No, and that's why you find different therapists specializing in different areas because that's where their comfort level is. That's where they've done additional training. That's what they're interested in. So, I don't purport to be a specialist in any areas that I don't focus on a lot, but the areas
exactly.
I do focus on, I'm interested in, and I do a lot of additional upkeep type of reading and training and conferences, all the things that one would do. So, um, well, this has been a really great conversation, and I really appreciate all of the information you've shared. And I think it's very educational, and that's why I do this is to, help fill a little bit of that educational gap about some of these issues. So if somebody, well, so you're licensed in Maryland only, is that correct?
That is correct, until social workers have a like a side pact.
Right, right.
I'm
Well,
not gonna do the like DC, Virginia, and up. No.
yeah, no, it's a lot of paperwork. But if there is someone who's watching this and they are in Maryland and they would like to get in touch with you to talk about their situation, how could they find you?
So I'm at a practice called Zen Psychological Center. So you can just Google Zen Psychological Center and fill out our form on our website. We also have all of our clinicians are trained in I-CBT and ERP, some offer ACT. Um, and yeah.
Fantastic. Great. Well, again, thank you for taking the time. Thank you for sharing your knowledge with us. Sounds like you do great work there, especially the intersection of the eating and the OCD. That's really, really
Oh yeah,
specialized.
I did want to add something to that before
Sure.
we end this. Is one of the things that pops up is people get really far in their eating disorder recovery, then OCD sneaks in there. So you know how OCD kind of goes after the things you care about the most? Well,
Mhm.
when you start really like loving just like not having an eating disorder, then you can start doubting your recovery.
Mm.
So let's say you go to a restaurant and you feel fullness or something like that, and then you're like, I can't finish my meal. That can trigger that doubt.
Wow.
And you can be like, well, what if I'm real? I get it all the time with people. A lot of people actually do see me after they've done some higher level of care and things like that, and their OCD is just spiraling and attacking their recovery.
Mm.
So
Wow.
that's another thing to look out for too. And, just with anybody working with someone with OCD, there's reassurance that people are seeking, right? They try to put you in that thing. And that's why it's just so bad to see a provider that doesn't really get OCD, is that they're going to just give into that. And I experienced that myself. I was so anxious and just needing reassurance all the time. And I just got sicker. Um, but being able to kind of like stop that reassurance trap and let them just, in eating disorder recovery, I think people get to really define it for themselves too. Like we have this idea of like what recovery is, but it's we deal with food all the time. Some people have medical conditions where they might actually have limitations and things like that, or be on medications where appetite, like ADHD medication, that's a huge thing, right? People take it and then like, well, I'm not hungry. It's like, yeah, but the recovery mindset is you still have to eat and you should be eating. So if you're still fighting through those things, but that's where OCD can really sneak in and be like, well, what if I'm relapsing because I was immersed in a special interest or something like that and didn't eat. Oh my God. And then the people just spiral. So that's
Yeah.
like some of the stuff that I see a lot, is where people are actually pretty stable in their eating disorder recovery and then start to doubt it.
Right.
They feel like they're relapsing. So
Wow. That can really kind of play with your mind.
yes, yes, yes.
Geez. Well, thank you for sharing all of this information, and hopefully, the people who are in need of the information will be able to watch this podcast, see what, they need to know, learn how to ask the right questions. If they can't work with you, if they're not in Maryland, find someone else who, works in the same area. There is the International OCD Foundation website, iocdf.org. They have a list of therapists who, you know, treat OCD, and because they're part of the organization, different from some other listings where people can say they treat whatever, but there's no real background to check that out. So that's a great place. Another one is Anxiety and Depression Association of America, ADAA.org. Also is another place where you'll find a lot of OCD therapists. Um, what about eating disorders? Where would they
Yeah.
find people?
So with eating disorders, we have the Academy for Eating Disorders. We also have the International Association for Eating Disorder Professionals. And there are a lot of fantastic organizations out there that also kind of can help people find eating disorder treatment, like the National Alliance for Eating Disorders. So there are a lot of other organizations. One thing to look for too is um, with eating disorders, because of the different bodies and stuff that people like, a practice like someone like me or whatever, I recovered into a straight sized body. So if someone has different lived experience where maybe they are just in a fat body, and I know I keep using that word, that's what we use in my field, which may strike people like, they're saying like fat, and what is that about? So there's this whole fat liberationist movement that's really looking into how health and weight, just that link is not really, it's actually more like a U shape
Hmm.
when you look at the health risks with certain weights and things like that, and that should not be our focus. And I can go on a whole tangent about why the BMI is trash, but that's for another time, I guess. But yeah, so we have a lot of different things. So there's something called body trust, and I'm actually in the process of finishing up my training in body trust. So these are providers that are very sensitive and aware of all these systems of oppression that might, kind of lead you down the path of having an eating disorder, or any really poor relationship with your food and body and things like that. So body trust is another thing to look for. And yeah,
Wow. Okay. Well, that's good. So there's
there's a lot of stuff out there. Things are changing. The eating disorder field, to be honest, has been a little bit on fire this past year. It's pretty active, more in the social justice piece, and it's actually really exciting for a lot of us to see um, things kind of changing and moving in directions that are more inclusive for people in marginalized bodies.
right. Right. Great. Well, this is all good news. So, okay. Well, thank you again for your time. And maybe we'll have you back on and do another podcast about all of these additional
The
issues,
BMI.
the BMI. So,
Why your weight does not actually mean anything about your health, which is actually really good education to have for anyone with health anxiety.
right, right.
So,
All right. Well, we'll talk about doing a podcast on that then, because it sounds like there's a lot of info that could be
there's
useful.
so much, and I'm an info dumper. So,
All right. Well, thank you for today's podcast, and then we will follow up on additional options.
all right.
Thank
Thanks
you.
for having me.
Sure.